You can start. So, good morning,
Yeah.
everyone. Today, Rochir will be presenting the case and it's
And
moderated by
I can
Professor
see
Ramesh
that
Ardhanari.
Phanikrishna has joined. Hi, Phani, how are you?
Good, sir.
Yeah,
Good.
it will be moderated by Professor Ramesh Ardhanari, Professor Venkatrami Reddy, and Professor Phanikrishna. I think it's all yours, Ramesh, Phani, and
Yeah, we
Venkatrami
can
Reddy
start
take
with
over.
your history. You can start presenting.
Okay. Good morning, everyone. So I'll start with my case. My case is a 27-year-old female, resident of West Bengal, unemployed, presented with chief complaints of pain in upper abdomen in the past 4 months and upper abdominal fullness in the past 2 months. The history of presenting illness: the patient was apparently all right 4 months back when she started noticing dull aching and continuous pain in the upper abdomen, mild in intensity, non-radiating, occasionally aggravated by food intake, and relieved by oral analgesics. There is no recent change in the character of pain. She also gives history of sensation of epigastric fullness, which was aggravated occasionally after meals and persists in between meals in the last 2 months. There is no history of early satiety, abdominal distension, no history of hematemesis or melena, no history of altered bowel habits, no history of jaundice, fever with chills.
You don't have to keep reading no history. You can say no history of jaundice, fever, loss of weight. You can say, make it a continuous sentence.
Yes, sir. So the patient does not have any history of loss of weight or appetite or any other similar complaints in the past, or any history of chronic intake of any drugs or any previous blood transfusions, any blunt abdominal trauma, or no history of any other bone pain, back pain, or respiratory distress. The patient is...
Can I just stop you for a second?
Yes.
What are the importance of blood transfusions in this case here? Why they have specifically mentioned no history of blood transfusions? See, when somebody gives you something, that means there has a reason behind it. I myself am not able to make out the reason behind this one line, why they have written that. I mean, normally in a history like this, we may not even ask for the history.
Yes.
But they've asked for it and they've mentioned it. Now, why did they do that? Is probably that it's a retrospective question and they thought it should of importance to present.
Yes.
But I don't know what it means. And see, I can understand the history of blunt abdominal trauma.
Yes.
She could have sustained a pancreatic injury, and that could be now causing some symptoms. The bone pain, back pain, she could have a malignancy somewhere, she could have metastasis, she could have back pain because it is pancreatic pain, it's upper abdominal pain, agreed. Yes. No loss of weight, appetite is just to tell you that she has not lost weight and appetite, so she's well preserved and doesn't look in malignancy. One of the premier things is in abdominal malignancy is to lose out. So all the other things make sense to me. Jaundice and fever with chills, yes. Upper abdominal pain, you're thinking whether it's a bile duct stone or it's just a common or a gallbladder stone. Makes sense. So, but this chronic transfusions, I am not able to understand the relevance at the moment. Would the other moderators
probably in relation to her hepatitis B, hepatitis C, transfusions and chronic drug abuse. I mean, I think
I understand that, but then there is nothing to suggest that she's suffering from a hepatitis B or hepatitis C. No suggestion of a viral hepatitis. So why this such an important statement in the middle of the history? I couldn't understand. So we'll keep that in mind. That there's something. See, they must have put it with some reason, hopefully, and we may come to it as we go along. Go ahead.
The patient does not have any significant past history. The personal history is unremarkable with mixed diet, normal sleep and appetite, normal bowel and bladder habits. She is not a smoker or alcoholic, and no significant family history. To summarize my history, the patient is a 27-year-old unemployed female with 4-month history of dull, continuous upper abdominal pain, occasionally aggravated by food and relieved by analgesics, along with a 2-month history of epigastric fullness that persists between the meals. She does not have any other significant history, unremarkable past surgical, medical, and personal history.
So, with this history, what are you thinking of? What are your lines of thinking?
Sir, the first and foremost, because she is having an upper abdominal pain I will not be able to, according to the history given, I will not be able to point towards a particular organ or a particular pathology, but I would like to keep certain organs in mind to proceed towards examination to come to a certain organ of origin of the pathology, sir. But my initial picture up from the history would be something related.
So what are these organs that you are now keeping in your mind?
Yes, sir.
Make it clear.
Yes, sir. So because the patient is having pain aggravated by food and relieved by analgesics, and also the epigastric fullness, the first thing what I would think about it's something related to the stomach with some dyspepsia picture.
Okay.
Then
So stomach is high up in your ranking, which I think all of us would agree. Yeah.
Secondly, sir, because of the young age and also the upper abdominal location, after that I will keep pancreas in the second after the stomach, some pathology related to the pancreas, sir. And so that are the two things which I'll keep in mind and I'll move on to the examination. But other than that, I'll not be able to pinpoint towards any other pathology from this history.
Why not the liver?
So because the
It all
so liver-
fits into the liver also, no?
yes, the
Liver.
liver can also be there because of the upper abdominal location. Yes,
Remember that one line, blood transfusions.
yes, sir.
So something hinting towards the liver, maybe, we don't know.
Yes, sir.
That's why that was made, maybe that line. You
Yes.
know, somebody in retrospect thought we should write this. See, criticality in thinking is very important for clinicians. I'm not saying surgeons or physicians, everybody. We rely too much on investigations now, but we, at least Pradeep and I come from a generation where clinical history taking and examination was the most important thing to end up with a diagnosis, because we didn't have all these fancy instruments. Ultrasound was just coming in when I was a postgraduate. CT scan was only a head CT at that time. It became a body CT only after about another 5-7 years. So none of us went through the training learning these things. So we had to take history and findings and, make clinical diagnosis. So we were from that generation. So we are always looking at all the lines with a little criticality to see what is wrong, what is going on. So I think he's right. You should not forget the liver. So you see, you have actually 4 major organs in that area you're talking about. You have the stomach, 1. You have the left lobe of liver, 2. You have the pancreas, 3. And you have the transverse colon.
Yes, sir.
The transverse colon, she has no history of bowel habit alteration. She has no loose stools or bleeding. So transverse colon seems to be ruled out from what we can make out.
Yes.
I mean, it could still be something in the transverse colon like a gist or a exophytic growth, which is not the same, but which is pressing on something and causing all this problem.
Yes.
Okay. Now, though it's upper abdominal, do you think it could be spleen?
Sir, from the history, it can be, sir. Spleen can be there because of the dull aching character of pain, sir.
Your patient who is from West Bengal,
Yes, sir.
in place where there's a high incidence of extrahepatic portal vein obstruction and non-cirrhotic portal fibrosis. So portal hypertension, A.K. Basu, the original papers on portal hypertension came from Bengal. His papers are renowned even in Japan. The Japanese surgeons came to visit him and see his follow-ups. So we should not forget the spleen also in that area. The left lobe of liver and spleen are very close. So you have a large spleen that could have a dull, continuous upper abdominal pain that can cause fullness after eating because the spleen doesn't allow the fundus to expand. And when you have a dull aching pain, you take an analgesic, it will relieve the pain. So don't forget the spleen.
Yes,
It also has this thing. Venkatrami and Phani,
Yes, sir.
your comments?
What do you think the pathology could be? Like you said, it is stomach. So what do you think in the stomach, what it can be? Like liver, what it can be? Pancreas, what it can be?
So from the history, I'll not be able to comment on the pathology. I'll keep a very benign picture in mind with I was thinking about
No, but that's an important point that you're
Yes,
saying.
sir.
You're thinking of a benign disease.
Yes,
See,
sir.
that is
That's
what
it,
he is
yeah.
asking. Exactly
Yes,
what
sir.
he's asking.
Yes, sir.
So you have already, with all this history, ruled out a likely malignancy. So
Malignancy.
it's a very important point that you have done. So your diagnosis is now restricted to a group of benign diseases
Yes,
in
sir.
your mind.
Yes, sir.
It may change as you examine the patient and see, but at the moment it changes the.
Yes, sir.
So don't say that I can't make any pathological. You've
Yes.
already done that. You ruled out malignancy in one
Malignancy.
go, which we all agree.
Okay,
So
sir.
I think that is important. Yeah.
Yes, sir.
I mean, in this kind of a patient, the history of weight loss and loss of appetite, and even negative history is very important because that points to either a benign or a low-grade pathology, not necessarily, something like a pancreatic adenocarcinoma, gastric adenocarcinoma is less likely with 4
Yes.
months of history and no weight loss.
Yes, sir.
So you can say something, pathology, stomach, what it can be. Liver, if it is something like hemangioma, something like that. Can you
Sir,
have some differentials before?
Sir, in benign, if the organ, if I start with stomach, I'll keep the gastrointestinal stromal tumor in the first, what I would think about from stomach. From the liver, sir, it can be a simple liver cyst, but because of the pain, I'll not keep that. I'll keep a benign tumor like hemangioma or a hepatic.
Why do you think of GIST as your first diagnosis? I mean, here your patient has got abdominal pain,
Yes,
occasionally aggravated by food, has fullness sometimes after eating,
yes,
something to do like a gastric ulcer or a duodenal
Yes,
ulcer with some element of obstruction, not complete but partial. That's why she has fullness. Is perhaps the first I would have in my mind. And then I would investigate for GIST is a relatively rare tumor.
yes.
It could still be GIST, but that is a different thing. But in the OPD, when you sit, 99% of dyspepsias are something to do with the gastric
Yes, sir.
mucosa. They have gastritis, they have H. pylori infection today, they have duodenal ulcer, or they have multiple erosions, or they've got NSAID abuse. They have got
Yes, sir.
something to do with the gastric mucosa. It doesn't come from the stromal tumors.
Yes,
The stromal tumors are rare.
yes.
So that is
Pancreas?
one on stomach.
Yeah.
What about pancreas? He asked you.
Yes, what do you think can be?
Sir, I would think about mild attack of pancreatitis in the initial.
What pancreatitis? You have to define. There are two types of pancreatitis. You have to tell which pancreatitis.
Sir, I would keep gallstone pancreatitis, sir, in.
Is this the history of gallstone
No,
pancreatitis?
sir, it is not a history of gallstone pancreatitis, sir.
Then what pancreatitis is it?
Did she
4 month
have
history.
any? Yeah. Did she have any that severe history anytime?
No, sir, she's
No.
not having any history like that.
So she has a dull aching pain, 4 month history, aggravated by food at times. So what pancreatitis do you think of?
Chronic pancreatitis, sir.
Yeah, the history. See, 4 months don't say acute pancreatitis, please.
Yes.
Let us be very clear. Acute pancreatitis, the patient would have said severe upper abdominal pain, debilitating pain. You have seen patients with acute pancreatitis. Even the mildest attack of pancreatitis, for 24 hours, they may require fentanyl or morphine. So they require high level of analgesics. This is not that type of pain. So this is not acute pancreatitis. As of now, there is nothing in the history to contribute. We are only talking of the history, nothing to contribute. So I would think at all, if at all, a chronic pathology in the pancreatitis, and maybe even a cystic neoplasm dragging on the pancreas causes pressure on the stomach. So it's a huge mass, then the patient can't eat. See, all this fullness and everything can be explained by huge masses because they don't allow the stomach to expand. Okay, go on to the examination.
Okay. General physical examination. The patient is conscious, cooperative, and oriented to time, place, and person. Her BMI is 22.8 with a height 22.8 with height of 155 centimeter and a weight of 55 kg. She is moderately built and nourished, well preserved.
That's a duplication, isn't it? You're given BMI.
Yes, sir.
Then we know that she is actually well nourished. No, she is in the normal BMI range. So the second line, it doesn't have to be read at all. I will keep one of the two lines.
Okay, sir.
She is moderately built all right, but she's well nourished, and that is true. And that is proved already by the BMI. So no need to talk about it. Now
Okay,
go to ECOG.
The ECOG status is 0 with a breath holding time of 45 seconds. She does not have any pallor, cyanosis, icterus, clubbing, lymphadenopathy, or any edema. She is having pulse rate of 86 per minute, blood pressure of 120 by 70 millimeters of mercury, respiratory rate of 18 per minute, and she is afebrile. There is no signs of any enlarged left supraclavicular lymph nodes and no signs of cellular liver failure.
What are the signs of cellular liver failure that you look for in any patient, if you're looking for?
Sir, from head to toe, it will start with the signs of jaundice, sir, with hirsutism, then
Hirsutism.
no, sir, not hirsutism, sir.
Hirsutism
Loss.
means like a bear. You know, he's got
Loss of
hair like a bear.
The reverse, sir.
more
What
of
do you have?
losing hair, no?
Losing hair, yes, sir.
You'll be losing hair. Frontal baldness comes early. Then what else?
Sir, I'm not able to recollect
You
all
can't
these
recollect at least the common ones, man. Atrophy of proximal muscles like deltoid.
Yes, sir.
Okay. Gynecomastia.
Gynecomastia.
What is the commonest cause of gynecomastia in patients with liver cell failure? Where do they get gynecomastia? And since you don't seem to know, most people answer that it is because the liver is not working, the testosterone is changed into estrogen, and therefore they get that is not actually true. The commonest cause of gynecomastia, 99% or even 95% out of 100, is the use of spironolactone in the treatment of ascites and liver cell failure. So they have ascites, so you treat that with spironolactone, and the spironolactone causes gynecomastia. So that is the commonest cause. Please remember this in clinical practice also. This is the commonest cause. And it's usually a painful gynecomastia. So they have painful gynecomastia. Yes, they have had, and because of that, the testosterone levels low, they'll have atrophic testes. They'll have loss of pubic hair and axillary hair. Okay, they'll have palmar erythemia, Dupuytren's contracture. They may have clubbing, and if they have obstructive jaundice, they will have scratch marks, especially over the tibias. Okay. And pedal edema is again in liver cell failure, a peripheral sign of liver cell failure. So you see, there are certain standard questions that have to be mugged up. The answer has to be mugged up for the rest of your life. When you answer that question, whenever I just rattled off everything. You know, this is what I mugged up in my MS days, and I just rattled it off. I don't have to think twice. So you also have to develop that habit. There are certain questions for which you don't have to think. When they ask you what types of splenomegaly, small, intermediate, large, and each differential diagnosis, mug it up. These have to be mugged up so that you know them, so that you don't hesitate. There are certain things that you don't mug up. This is one of those things.
Yes.
Okay, so we have no signs of liver cell failure. Proceed.
On the abdominal examination, the patient is having a centrally localized umbilicus inverted with visible fullness predominantly over the epigastric region and which is extending to the umbilical region. The patient, all the quadrants of the abdominal are moving correspondingly with respiration, no scars, visible peristalsis or any skin nodules or any engorged veins. The hernial orifices with no visible cuff impulse and no renal angle fullness. On my palpation, she is having a 10 by 8 centimeter firm, non-tender, non-pulsatile lump with a smooth surface is palpable, predominantly in the epigastric region and extending to the umbilical region.
You cannot have a 10 by 8 centimeter lump in the epigastrium, which is non-pulsatile. I'm sorry. It just doesn't fit. Every lump in the epigastrium of that size is pulsatile. The question is whether it's expansile or transmitted. Okay, that's a different question. But they will all be pulsatile because they're all sitting on the aorta. If they're 10 by 8 centimeters, you're feeling them to, that means they're sitting in the height also, they're some size, and they'll be sitting on the aorta. She's a thin woman. 100%. I'm telling you, you don't even have to palpate it. If you watch it, that abdomen would have been moving in the epigastrium up and down. 100%. So always it is palpable. So be very careful before saying, or you make yourself say it's not an expansile lump, there's a transmitted pulsation. That's to be sure, because I'm sure it will be pulsatile. Yeah,
The
go on.
upper border is not palpable and the lower border is palpable at about 2 centimeters above the umbilicus. It is extending laterally to the mid-clavicular lines on both sides. It moves with respiration. It does not have any intrinsic mobility. On leg raising test, the lump does not become prominent, and on lateral decubitus test, the lump does not fall down. The rest of the abdomen is soft and non-tender.
Is that a correct way of telling that the lump falls or does not fall? It has to be knee elbow position. I know you can't do it, but lateral decubitus, whether it falls or not, doesn't tell you whether it's retroperitoneal or intra-abdominal. No, sorry. Lateral decubitus will not tell you because it is not, the gravity has not worked on it completely. So you have to go on the leg, on the knee elbow position, which you are not going to do because that's uncomfortable for the position. And today, nowadays, we don't do anything in the examination which is uncomfortable to the patient. So you can tell we have not tested the knee elbow, so I don't know. I have no comment to make. But lateral decubitus is not a answer to the knee elbow.
Right.
Okay.
The patient does not have any hepatosplenomegaly and the hernial sites are not having any palpable impulse. On percussion, the dull node is present over the lump and it is continuous with that of the liver dullness. The flanks are tympanic. Auscultation, normal bowel sounds are heard. On digital rectal examination, normal anal tone, no hard nodules, and glove finger is stained with yellow colored stools. On systemic examination, normal cardiac examination, respiratory system is normal with air entry bilaterally equal with normal vesicular breath sounds, no Krebs and Reddit sounds, no focal neurological deficits. Should I summarize the case, sir?
Yeah.
27-year-old unemployed female from West Bengal with a 4-month history of dull continuous upper abdominal pain, occasionally aggravated by food and relieved by analgesics, with a 2-month history of epigastric fullness that passes between the meals. She does not have any other significant history. Examination reveals a 10 by 8 centimeter firm, non-tender, non-pulsatile lump with a smooth surface predominantly in the epigastric region, extending to the umbilical region, moving with respiration but without any intrinsic mobility, does not fall down on the lateral decubitus test. Rest of the examination are remarkable and unremarkable past surgical, medical or personal history.
Okay, with this, now you have the findings of examination to add to your history.
Yes.
Where organ of origin, pathology of the disease, what is your take on it?
Sir, from the history and examination, now the organ of origin I'll pinpoint first would be pancreas, sir. Second would be liver, and in the pancreas, I would be thinking about a cystic neoplasm of the pancreas, sir. In the liver, I'll be keeping differential of a benign liver lesion and
what benign liver lesion you will think of?
Yes, sir. Sir, either hemangioma or
commonest of the benign tumors is a hemangioma. Therefore, hemangioma will be number 1. Yes, agreed.
Followed by, sir, hepatic adenoma, sir. That is, this two I would keep in liver. And
oral contraceptive intake was not given in
no, sir, no
detail. So adenomas, I don't know, very strong correlation with oral contraceptive intake, isn't it?
Yes,
I'm sure they would have mentioned oral contraceptive intake if the pathology were an adenoma, isn't it?
Yes, sir.
Yeah.
Yes,
but now your blood transfusion comes into picture.
Yes, sir.
Now.
Yes, sir.
So what does that tell you? They specifically mentioned no blood transfusion. So what are they trying to tell you?
Sir, to
go on.
Rule out any history of to rule out cirrhotic or any hepatitis.
So you are not thinking of cirrhosis of the liver, portal hypertension, and there is no viral etiology which is blood transfusion carried, which is both B and C, which cause chronic liver disease.
Yes, sir.
Okay, so that is why they are giving you that point. They are
Yes.
telling you that there is no viral etiology to tell you that there's a chronic liver disease. Basically, that is their thing.
Yes, sir.
Suppose you had been examining this patient, would you have looked for something else apart from what all they said? Something could have been said. They should have said that also.
Sir, in the palpation, one would be to be able to insinuate between the.
That they have written. You could not insinuate. They've written that there.
Yes, sir.
They did write that.
No, sir.
If you read that, they said it is not upper
Yeah.
border is not palpable. See, the upper
Yes,
border
sir.
is not palpable, so they
Yes.
cannot insinuate. Huh?
Yeah.
What else do you think?
How did you rule out stomach now?
Sir, on the basis of history, sir, and I
No,
will.
but history you kept stomach as a
Yes,
differential.
sir. From the
You can't
history, I
say
kept it as that. But sir, after the examination and the mass, sir, with the symptoms, I kept it at the end, sir. My first organ would be pancreas, second would be liver, sir, and
Yeah. So the most important thing was it was not moving.
yes, sir. Moving.
Yeah. So stomach usually moves with respiration.
Yes.
Or moves intrinsically. So you didn't have any mobility.
Yes,
So the stomach, unless it's fixed to the posterior abdominal wall,
Yes.
and a stomach fixed to the posterior abdominal wall means it's a malignancy. Stomach of that size, malignancy, she would have been very symptomatic. She would have lost 5-10 kilos of weight. She would not be eating. She would be looking very sick, which she is not. She
Yes.
looks good. ECOG 0, BMI normal. So obviously, you are keeping it low down. I think most of us would agree with that. But I've asked you a point in examination
Yes,
which
sir.
you have not told me yet.
Sir,
So this is a patient on which they should have told you where there are visible veins on the abdominal wall.
yes.
I think it's
For that, they
mentioned.
would
Yes,
did they
sir.
mention it?
Yes,
Did they
sir. No
mention it?
engorged veins, sir. Yes, sir. No.
Okay, then it's fine. So they've written no engorged veins. So that rules out any IVC block
IVC complete.
or anything that tells you. So that is again a clue to tell you that it's not from the right lobe of the liver or the caudate lobe. If it is from the liver, it's from the left lobe of the liver.
Ruchir,
Yes, sir.
but two differential diagnoses. One is a liver mass, which is going up till the umbilicus, and a retroperitoneal pancreatic mass, which is in contact with the liver, right? There's one very important examination point on palpation or percussion. I'm giving you a clue, which is very pertinent to differentiate between these two.
So the lateral decubitus test, in which the lump is does not fall.
He gave you a hint. He
Yes.
said in palpation or percussion. Now,
Yes.
why did he tell you percussion?
Going from the costal border to the umbilicus, what
Yes.
would you look for specifically to differentiate between retroperitoneal and liver mass?
Sir, one would be in palpation to be able to insinuate between the mass and the liver, and second would be the liver dullness. The mass is continuous with that of the liver dullness, sir.
What
So
else?
that is what?
What else? The liver is dull.
Sir.
But suppose it was pancreatic, what would you expect?
What would you expect? Pancreas going from the costal border till almost below the umbilicus. What would you expect on the?
Sir, it would be
finding?
yes, sir. If it is a pseudocyst or a cyst, sir, I'm not
So-
sure. I'm not able to.
You would have had a band of resonance, no?
Yes.
Either the
Band of resonance.
transverse colon and the stomach would be in front.
Okay,
So
Yes.
that would be a band of resonance. That's what he's hinting. So
In fact, in
liver
the
is
examination, you
completely
should
dull.
mention that as even as a negative point when you have this in your examination findings. You should. I don't find a band of resonance is an important point, and that it's surprising you didn't find it, but yeah, they didn't find it.
So these are not big things in the modern investigation, but these are big things when I was doing an MS because we had no investigation. So we had to make our diagnosis on clinical and then post the patient for surgery based on that only with just the blood test, no other tests.
Right.
Okay. So now you got this. So you have put pancreas, left lobe of liver, stomach lower down,
Yes, sir.
transverse colon you're not thinking of. Okay. So let us go on to what you want to do with the patient. What investigations you'll ask for?
Sir, first I'll start with the blood investigation, starting with the complete blood count, the routine blood workup, including the complete blood count, renal function test, liver function test, sir. These three I would order.
Can you give it to him? I'm sure you have it ready. Somebody can just show it in.
So the complete blood count is showing an normal picture of hemoglobin of 9.6, total count of 9,000, and platelet of 3 lakhs. Next, renal function test is also normal. Creatinine of 0.62, electrolytes are normal. Liver function test is also normal, sir, with no abnormalities.
An albumin that you would expect it to be a little better compared to her
Yes, sir.
nutritional. So the albumin is marginally lower, I would say,
Yes,
in
sir.
her at 3.7. You see, this is very important to remember that suppose you have to do a major operation. Okay, you will notice that within 48 hours, the serum albumin will drop dramatically. So when you start with 4.5, the drop may be down to 3.2 grams, but it will drop. When you start with 3.7, it will drop down to 1.7, 1.8. And at that stage, you know that you get edema, you get the bowels edematous, you get pedal edema, the patient is waterlogged, and then you have to really, so the albumin of 3.7 is not absolutely normal to me. It is a little below normal. In India, we accept 3.5 and above as normal. But would I do a Whipple at 3.7? Yes, probably. If there's no jaundice and a young patient, I would do. But if the other 5 factors are not good, 3.7 to me is something that may tilt the balance. So I would look at that with a little bit of a jaundice dye.
Yes.
And OT is also little abnormal, SGOT?
Sir.
Hello.
Nearly, sir.
It's getting so much, man. SGOT is abnormal. And even the HB of 9.8, I mean,
Thank you.
9.6 or something, it's on the lower side. It may have relevance. I mean, you could again go back into the history and any menstrual abnormalities you would ask, or to this lump as well. So 9.6 again is not normal.
Okay.
On the lower side.
Yes. Yeah, but most Indian women and see, most Indian men, if you look at our hemoglobins, 12 is about the average that we have. Very few of us go to 15 or 16. 14 itself is abnormal. My hemoglobin is usually somewhere around 12, 12.5. And most of the doctors in my department, I've seen often, the results, they're all in that same group. So men and women in India tend to have, because we don't eat red meat. You see, the red meat gives the foreigners the iron to bring. And our people don't eat enough of the kirai. You have to eat a special kirai called Murunga kirai that comes from the drumstick tree. That kirai is the one that has a high content of iron. And amla has vitamin C and some iron also, I think. So these things we have to take, we don't take sufficiently. So I think most of us are iron deficiency. Almost 90% of Indians are vitamin D deficiency. Did you know that? When they did the studies, because to get vitamin D, you have to be in the sun between 11 and 3 in the afternoon. We are not in the sun between that time, except the farmers. So all of us in the cities are deficient of vitamin D. So just as a side, this thing that hemoglobin also maybe because of that, we are all a little low because the diet doesn't support us having a good hemoglobin.
Yes.
So you have to eat red meat for getting hemoglobin. Red meat means beef, deer, mutton is not red meat. It doesn't produce that much iron. Carry on.
So the INR is also normal, sir. So now next investigation radiologically, I would proceed with the ultrasound abdomen, sir.
I am very happy that you said ultrasound abdomen. Most of us ignore that nowadays and we just ask for a contrast CT. You said ultrasound, excellent. We will have the ultrasound because that is your guide. Today, ultrasound is an extension of clinical investigation. It's your guide to what you want to do in further tests. So what's the ultrasound report, please? Okay, there it is. Read it.
Yes. So the liver is showing us hyperechoic mass of 66 by 5 by 4 in the segment 7 with 60 areas. Biliary system is not dilated. Normal gallbladder is also fine. Pancreas is replaced by a large heterogeneous mass lesion with multiple cystic areas with mass effect on the porta hepatis, splenic hilum, and posterior wall of stomach, measuring 114 140 by 121 by 88 mm. Rest is normal.
Next line is important.
Yes, sir. No fluid, free fluid or abdominal pelvic lymphadenopathy.
No,
What about spleen?
you
Spleen.
skipped
Yes, sir.
spleen.
Increase in size.
So you made differential diagnosis. Both are correct. You have a liver mass and you have a splenic mass and it's a pancreatic mass. And your spleen is enlarged. So all three are right. So your all your differentials are now fitting in.
Yes,
and with this ultrasound, what do you think that this represents? What do you think that this is?
So there is a lesion pancreas and also liver.
Yes, sir. So the pancreatic lesion is heterogeneous with multiple cystic areas. So that is a cystic neoplasm. And I would think about a solid papillary neoplasm in this scenario. And
pancreatic neoplasm, okay.
I mean,
liver?
age and sex are very important, especially within a cystic neoplasm. So anything else other than SPEN? Anything else you have in mind?
Normally, the ultrasound description of SPEN doesn't show much of cystic areas. It shows a predominantly solid mass. Here, if you look at it, it says multiple cystic areas.
yes, sir.
So,
And you put SPEN as your first diagnosis. What's the incidence of metastasis? I mean, if there's a liver SOL of similar nature, what is the incidence of metastasis in SPEN? Any idea in the literature? Is it less or high?
Sir, less, sir.
It's very rare.
it's not usually a
Very-
malignant tumor, isn't it? SPEN is not a malignant tumor. So,
Yes, sir.
so if that lesion in the liver is metastatic as what we all think it might be,
Yes, sir.
What else
it's
would
not
it
likely
be?
to be SPEN. What else? Cystic neoplasm, right? But what?
Which other cystic neoplasm is commoner in females when almost exclusively in females? Any idea?
Sir, almost all this mucinous cystic neoplasm, sir. MCN, sir.
Yes.
No, is
always
it likely
been-
to be a serous cystic neoplasm?
No, sir.
Yeah. So the way it looks, it doesn't look to be a serous adenoma. Serous adenoma comes in elderly women,
Yes, sir.
isn't it? This is not the age group for serous adenoma. But for cystic neoplasm mucinous, this is the age. And secondary is in the liver, possible.
Yes, sir.
And then you have to say not cystadenoma, but cystadenocarcinoma.
Yes, sir.
Yeah. But then we had ruled out malignancy.
Yes, sir.
No loss of appetite, no loss of weight, such a large malignant mass, no loss of appetite, no loss of weight. Very, very surprising. So what else you think of?
What else can come in pancreas apart from cystic
Look
neoplasm?
at the hyperechoic mass lesion with cystic areas.
Yes, sir.
What could it be? Would it be a hydatid cyst? And then there's another hydatid cyst in the pancreas.
Yes, sir.
You know,
So,
long history, no significant systemic effects, big cystic lesions. You know, hydatid is something you should always keep in mind in India. It still is around the thing, and West Bengal is one of the places where it is quite common. So we do see once in a while. Now we see less and less as people's hygiene has improved, but we can keep it in mind.
yes, sir.
Yeah, you should keep it in mind.
And the other thing you
Okay.
should remember is, I mean, this cancer cachexia, the loss of appetite, weight loss is more of a feature of gastric, pancreatic, gallbladder adenocarcinomas. Many times cystic neoplasms, HCC, neuroendocrine tumors is not that much of a feature.
Not that common.
Yes.
Yeah.
And
the
the cystic could have been a benign neoplasm for many
Exactly.
years
Point
and
well
now
taken.
undergone malignant change. So that's why in the 4 months she has become symptomatic. Maybe 6 months down the line, she would start losing weight and becoming sicker.
Nice.
So that's possible. Yeah. So now what? What will you do now? So let us look at what their impression is from the ultrasound. The sonologist's interpretation of the ultrasound, please.
Okay. I think they are not given. Okay.
No, they must be having. No, huh?
Sir, he suspected a pancreatic cystic neoplasm, possibly SPEN, with mets to liver.
Okay. So that's
Yeah.
what it is. Okay. Though we would disagree with SPEN because of the things which Funny has already made clear.
I mean, SPEN is
but it
possible,
is
but
always
very rare.
possible.
But it's very rare. 2% is we have had a case of SPEN with peritoneal meds, but it is a very rare thing. So
Very rare, very rare.
more common would be a SPEN with an incidental liver lesion of some other sort.
Yeah, some other cause. That is possibility again. Okay.
Yes.
So let us, what will you ask for now?
Sir, now I would like to do a CCT abdomen, sir, contrast enhanced abdomen scan, sir. With
Yeah,
IV
let's
contrast.
have it. Let's have it.
You have control switch.
Okay.
Give the non-contrast and then give the contrast.
Yes, sir.
Because of certain reasons, you would like to see a non-contrast in this patient. So what do you see on the non-contrast? That's what I wanted to see.
Sir, one would be evidence of any free fluid, sir. Other would be
No,
any...
what do you see? Don't say
Okay,
theoretical answer. You have the picture
sir.
in front of you.
Yes,
What do
sir.
you see here?
Yes, sir.
You see something definitely here.
Yes, sir.
What?
What is the one thing you look for in plain CT, man? Important thing, which is easy to see.
And it's seen clearly here.
White things.
Calcification, sir.
Yeah, you see the
Yes,
peripheral
sir.
calcification. See that you must also
Yes, sir.
say it's a peripheral
Peripheral
calcification.
calcification, yes.
It's not a central calcification. It's a peripheral calcification right around the wall of the cyst.
Yes, sir.
So that cyst is where is it coming from? No, really difficult to say with such a huge cyst that is very difficult to say where it is coming from. But seems to be, if you see the pancreas, you
Yes,
follow
sir.
it. It comes from the body of the pancreas. It looks like. Funny and Venkatrami,
Yes,
you
sir.
would agree, or you see
Yeah,
that?
yes, sir. Yes, sir.
On that
Yeah, it-
cut, but yeah, there.
yeah,
Yes,
See
sir.
there.
So it is coming.
yeah, there it
I
From
is.
the
mean, this
body of the
exactly in this image, if you see a liver SOL versus a pancreatic SOL, the pancreatic SOL will push the stomach to the anterior abdominal wall. You can
Yes,
see
sir.
that. While a liver would push it down. So that's
Yeah.
fairly clear.
And what else do you see now on the contrast? On the non-contrast, you see something else also.
Yes, sir. So there are cystic areas, sir, within
So
the
cystic or necrotic areas,
necrotic
maybe.
areas. Yes, sir.
It could be necrotic areas also. So,
Yes.
but there are areas which are large,
Yes, sir.
occupying about 30-40% of the volume. And then something else, which they had said on the ultrasound, you can see it
So
here
there is
also.
a lesion in the liver as well, sir.
In the segment 7, there is a
Segment
definite
7.
lesion,
Yes, sir.
and that's a separate lesion.
Yes, sir.
And to all purposes, from the plain CT, it looks like a metastasis. So let's see what it is on contrast, arterial contrast, please. So there's your arterial phase.
Yes.
So you tell me, what do you see on the arterial phase? Go slowly along.
So the lesion is enhancing on the arterial face, sir, with the
Yes.
more likely necrotic areas, sir, within the lesion, sir. With peripheral calcifications are persistent, sir. And
Keep talking, man. I mean, what are the important things you'd look for in the arterial phase? Which vessels, which findings?
yes, sir.
So you have to keep talking. In the liver as well, anything you're looking for in the arterial phase, and in this pancreatic lesion, what are the important vessels? You have to keep, best ways in the exam.
sir.
Once you see the PT, slowly start talking. If not, the questions will start coming.
Yes, sir.
If you keep talking, nobody will ask you much, at least, hopefully.
So on the arterial phase, the liver lesion also is enhancing, sir, heterogeneously enhancing lesions, sir, on the arterial phase, sir. And with respect to the pancreatic lesion, sir, it is
So they are showing you something again and again. You saw that. What is that?
with
What
respect
are
to
the
the
main methods you'd
arterial
like to look at in the arterial phase? Tell us.
sir,
One is the enhancement pattern. Okay. Anything
sir.
else? What are the main vessels
so the
in
main,
relation to this lesion you'd like
so
to look
because
for?
of the huge
Pancreatic mass, you
lesion,
said.
I would examine the relation of the tumor with the celiac trunk and also the SMS, sir, because it is it is a very large tumor, sir.
Exactly.
So the celiac axis, what is it? The hepatic artery that
Yes,
arises from the
hepatic
celiac
artery,
axis,
yes, sir.
that what does it show? Is it going through the tumor? Is it pushed by
No,
the
sir,
tumor?
it is pushed by the tumor, sir. Both
Yes, it looks like
both-
peripherally pushed by the tumor.
yes, sir. Both the
Okay.
hepatic artery and the splenic artery as well seems to be pushed by the tumor, sir. It does not seem to be going through the tumor, sir.
Yeah, so they seem to be pushed.
Yes, sir.
And so that is a good sign. I'm
Even
not
the
able to
left
see the
gastric
SMA, and the left gastric is seen
also
again pushed
yes, sir.
away.
Yes, yes,
I
sir.
can't see the SMA, and
Yeah, down you can come.
if you can come a little down. Yeah, there is the
This is
SMA's
SMA.
origin.
Yes, sir.
So keep following the SMA. There is no accessory hepatic seal arising from the
Yes, sir.
SMA. You can see in these cuts.
Yes,
That
sir.
doesn't look like it, but there's, I don't know whether there's a small branch going. Anyway, we'll have to see that on a recon, which will be required. Okay.
Yes, sir.
Go to the portal face.
Yes, sir.
I mean, in the arterial, I would also add that, there's no enhancement in the liver,
Yeah.
lesion. So
Yes.
that's more, and there's nothing to
Yeah, but
suggest.
the liver lesion was slightly enhancing in one or two
Slightly
places.
enhanced. Yeah. And there's nothing
Not-
to hemangioma, which, the peripheral nodular enhancement is not there.
So what do you think of the portal vein?
Sir, portal vein, the left branch is looking fine here, not compressed, sir. This is the right
So
branch.
again, the
This is
portal
also
vein
fine,
seems to
sir.
be pushed away, isn't
Push,
it?
sir, push, sir, but no.
It is not infiltrated. There is no thrombus. You must say that.
Sir,
There's no
thrombus.
thrombus in the portal vein. It doesn't look obvious. And
On the
in the
portal
portal
phase,
phase.
also the enhancement seems to be persistent in the lesion, sir.
yeah. But the necrosis is better now
Necrosis
because
is
of
better
the
now.
enhancement. You can see the necrosis better.
Yes, sir.
And the cystic areas, which are probably necrotic areas because they have no blood supply. Okay, do you have a arterial reconstruction to show us whether there's any artery from the SMA?
No, sir, we don't have any recon.
Recon, you don't have. Yeah, but in our institution, we have a standing instruction to the radiologists that for all patients with suspected pancreas and liver lesions, we want a vascular reconstruction mandatory with the fixtures. Because this is something that is, today we don't want to go in knowing, without knowing after doing a CT, whether there's an accessory or a replaced right hepatic, where the right hepatic is a double. It's also very important to see where the right hepatic arises from the SMA. These are all things which radiologists want to do. They just say SMA, right hepatic, but it makes a lot of difference. The SMA, right hepatic, could arise close to its origin from the SMA, in which case it will not go through the pancreas at all. It will go almost in the normal route in which the right hepatic would take, parallel to the common hepatic. But then it would come from the middle of the SM way, in which case it will go right through the Ansonite process and go into the liver. Now, those two are two different kettles of fish when you operate. The first one is very easy. You don't have to actually take any care. But the second one, you will have to divide the Ansonite over the hepatic and to preserve it. And if it's, of course, if it's involved with tumor, if it's already blocked, then you can just safely ligate it and then divide the upper end and see whether there's back bleeding. If there's back bleeding, you don't have to do anything else, just close it and come off. Patients will usually do well, provided they're not deeply jaundiced when you operate. That sort of patient, if you have jaundice, better to stent and then operate so that the bilirubin comes down and the liver will recover normally. And don't do any mobilization of the triangular or other ligaments so that there is completely all the collaterals are preserved. So you have to look at not only that there's an accessory, but where it is arising from. And the closer it is to the aorta from the SMA, the normal course it will take outside the pancreas. So this is a very important point you should look at. And that you should also be looking at the images. So you should also take it in your idea before you go in for surgery. In 2024, I believe that there is no role to go into a Whipple's operation or hepatic resection without knowing what the vascular distribution of the hepatic arteries are. To look for it behind here, peeling is not accept. You have to know it beforehand so that you can prepare yourself. In case you have to resect an anastomose, you are capable of it, you're a liver transplant surgeon, very good, you can do it. But then I'm not a liver transplant surgeon, so I would need the help of a liver transplant surgeon or the help of a vascular surgeon to reconstruct that artery. So I will call for help. And I will say that I'm now ready to divide. So they will harvest whatever vessel they want to replace it with. And then I will divide it and give it to them immediately so that within minutes they can put the graft. And most of these people are very good at it nowadays. So they do it very fast. So these are important points, I think, that we have to take. Okay, so now you have the images. You have the thing. What are you going to do now?
So next, I would like to proceed and do a US endoscopic ultrasound and do a.
Now what do you think is the diagnosis based on the imaging?
Sir,
Can we have the CT scan report? There you have the report.
So, does everything fit into cystic neoplasm? The CT findings?
heterogeneously enhancing lesion then by 8 centimeters out in proximal body region causing mild stream upstream dilatation. Encasement and thrombosis of the splenic vein with multiple perigastric collaterals, compression of the lesser curvature of the stomach, seen extending superiorly into the lesser sac, compressing lesser curvature of stomach, closely abutting portate, left lobe, and gallbladder. And intrahepatic biliary radicals are not dilated, well-defined heterogeneous.
So the ultrasound said splenomegaly, but there's no splenomegaly on CT. We also saw that. There is no splenomegaly. But there's a possibility because the splenic vein is thrombosed. So that could be the reason why ultrasound had said, but it didn't look like there was splenomegaly looking at the images. It didn't seem the spleen was large. Okay. So you have the report, you have the images. What you think the disease process is?
Sir,
don't show him the report. We will discuss his report, his ideas, and we can give our ideas, and then we'll see what the report is.
So I would suspect a cystadenocarcinoma with which like cyst which has gone a malignant transformation and leading to cystadenocarcinoma with a hepatic metastasis, which would be what I would think, sir, from the CT picture, sir.
Does the lesion has more cystic areas or solid areas?
Sir, more solid areas, and the rest of the areas more likely necrotic areas, sir.
What next?
What next? Oh, so what is your take on the fact that all the arteries seem to be pushed away, though the vein seems to be infiltrated?
Yes.
In a malignancy, you would expect the arteries also to be engulfed by the tumor, but here it looks as if they're all pushed away. So why do you think this has happened?
So because the cystic neoplasms, they have a less tendency to have any arterial.
Yeah, they have a less tendency, I agree.
Yes, sir.
And the other possibility, I already told you, no? It could have been a benign one for many
Benign
years and now undergone.
transformation.
So during that time, it pushed it away and now it has undergone malignant transformation. It has not yet infiltrated them. Maybe it will infiltrate them in 6 months. Okay, so what else will you do? So can we have the impression of the CT scan from the
any other diagnosis apart from cystic neoplasm you can think of? Because still I'm not very convinced that it's a cystic neoplasm. It's more of solid areas with some necrotic more than cystic it is. Can it be something else apart from cystic neoplasms? With a meta.
So because of the heterogeneously enhancing, I would not suspect adenocarcinoma, sir.
Agreed. Adenocarcinoma is highly unlikely. Yeah,
Can it
that
be
we also agree.
Even though it's a rare, can you think of a gist from pancreas?
Just that is the thing I was also saying. Retroperitoneal gist is a possibility, isn't it? And malignant, so it is metastasized to the liver.
Yes.
Yeah. So now, what will you do? You have to do something now. No, let us see the CT report. What does it say?
Yes.
Sir, their possible impression was first one would be a solid pseudo papillary endothelial neoplasm, and they also gave a differential of cystic neuroendocrine tumor and a just third possibility.
So they also thought along our lines. So what will you do now?
Neuroendocrine.
What do you think?
They have given, no? Like, what do you think is neuroendocrine? Is it typical of neuroendocrine?
No, sir.
It was not typical of neuroendocrine.
Why not typical? Tell us reason.
Sir, because the neuroendocrine tumor is more hypervascular and more homogeneously enhancing and not
bright enhancement,
yes.
isn't
Yes.
it?
So
it shines.
Less likely. Sir.
Yes. So unlikely, yeah.
Yes, sir.
But it's possible. It's not to be ruled out.
Very possible. Early, once it enlarges, yeah, you can have unusual necrosis and all that.
Like everything. So don't rule it out. It is possible. And say is a gist. So now what will you do?
So I would like to do a US endoscopic ultrasound and FNA, sir.
Why do you want to do a US FNA for such a large mass, where you can do under ultrasound a CT or under CT a true-cut biopsy, a much bigger biopsy of the solid area, targeting the solid area. You know the vessels are away, so you can move away from the vessels. Why go for the US and a tiny biopsy, which may or may not give you? Why not a direct biopsy? US is for a small tumor, which the radiologist will find it difficult to target.
Yes.
Here, you have a football. I mean, you don't need an US to tell you where to take the biopsy. And ultrasound through the abdomen. See, and the cost will come down. The discomfort will come down. And you'll get good chunk on this CT scan. And I mean, I would go for an ultrasound or a CT scan guided biopsy, leaving it to the radiologist. I will not, though I have US, we have all the facilities, I would not go for US in this patient. Phani and Venkatrami, your opinions?
Yes, sir. Definitely we agree with that. There's no need for US in this case because you're not going to get any additional information by US actually.
See, I think any
small lesion,
you should be able to justify yourself. I mean, that's important, right? So US as a diagnostic, in this case, when it's so large, the frequency of the EUS will not even be, it's so big that it won't be able to reach the vessel. So in terms of the biopsy, a trans-abdominal biopsy was a EUS guided biopsy. And if you feel there's any pros and cons, what do you say to justify it? So for the liver SOL, definitely, I mean, would you like to biopsy what? Which one would you like to biopsy?
Sir, first the pancreatic lesion, I would like to biopsy, sir. And also the liver lesion also, I would like to biopsy both of them, sir.
Why both? I mean, see, one is EUS. I would say you could say that transabdominal there might be a risk of rupture, bleed and spill EUS for the pancreatic. But why would you like to biopsy both? Why not just biopsy one first and see where you're going? Would not be the ideal approach, which is safer and simpler.
I see, the fear of now rupturing the tumor, everything is gone. It's already metastasized.
I
to
agree.
the
No, no.
liver.
If somebody says EUS,
No,
how do you
what I'm
justify
saying
your-
that it is already metastasized to the liver. So that fear you can. Suppose it was not, then your fear is genuine. That it could
Absolutely.
metastasize, you may rupture it into the prepectoral cavity. That fear is genuine. You have already metastasized to the liver, so it is not likely to harm the patient in any way. So
Yes.
that is something that I would believe strongly.
Yes.
I want you to now tell me what are you going to do next. So the biopsy has been done, but before the biopsy, would you like to do something? I will tell you straight away. Isn't this a case for doing some tumor markers?
Yes, sir. I would like to send a
Ah,
CA, sir. For the-
see. See.
Yes, sir.
Anything else?
Anything else?
CA99 also, sir.
Yeah, CA99. Even in
CA99.
pancreatic cystadenocarcinoma, CA99 can be raised. And
Yes.
with metastatic disease, you can expect it to be very high. So do you have the tumor markers reports? So there you have the CA99 is very low.
Yes, sir.
So suddenly the pancreatic origin becomes shaky because such a low CA99 is really shaky. A CEA he asked for. Have you done CEA? I may not have done CEA, so
No,
I
sir.
wouldn't have done.
No, sir, not.
They also not done. So I think CEA is not necessary.
Okay, sir.
Unless you're doing an FNAC of the fluid and then the CEA of that fluid is different for a cystic neoplasm. The serum CEA doesn't matter.
Yes.
Okay, now what? Now you have a CA99 which is low. Now your biopsy becomes mandatory.
Mandatory. Yes.
Yeah, what will you do in the biopsy report? Did you do a biopsy, please? So they did an FNAC from the liver, which shows metastasis of a pancreatic solid papillary, pseudopapillary neoplasm. Okay. Did you do any biopsy from the tumor? No. Yeah, there is a pancreas which shows pseudopapillary tumor of the pancreas. So cystic neoplasm, but there is no evidence of CA99 and the way they have said pleomorphic cells, that means it's a malignancy.
Yes, sir.
Now what will you do?
Would you ask for IHC or no?
No, sir.
I would do an IHC.
You do an
What
IHC in this kind of
I
a
would do
tumor.
an IHC.
Absolutely.
What IHC? There you are. See,
Beta
I've
type.
done all this. It's negative.
No, in this kind of an
I would
it's
also asked,
mandatory.
because of GIST, we had thought of a CD117. I would have done an IHC marker for CD117 also.
Okay.
A C-kit would have told you this way or that way. Yeah. But anyway, they are very clear that it's solid on the biopsy. So that may not be so important in this patient. Yeah. Now what? What will you do now? Quick.
Sir, I will like to go for a surgery, sir.
No, man. So any other workup?
I mean,
you have a liver SOL.
come on, man. You have a tumor malignant which is metastatic to the liver. You think
Jump.
surgery can cure this?
No,
Is
any
this
other
a
workup
patient?
even before you consider surgery? Anything else? That's it.
That's it.
You evaluate only the abdomen. You don't look for.
You have not evaluated anything else. So don't you want to do something more?
No? Would you like to do or not?
Metastatic workup,
What
sir.
metastatic workup? That's what we want to know.
Says CT of the chest, sir.
Well, you can do a CT of the chest, or else you can do a PET
PET CT.
CT
Absolutely.
of the whole body screening. Today, I think before you try to do such a major resection, which is potentially not curable, you would definitely like to know whether the lung mets, brain mets, bone mets, anything else. So PET is, I think, done. Have you done a PET, sir? So there they have done a PET.
Yes, sir.
There is no ascites. See, look at that. It is segment 6 and 7 clustered. So they have got multiple secondaries, it looks like. Okay. So looks like multiple secondaries in the liver. Now what? You see that? That report suggests that there are multiple secondaries, apart from the one large one we have seen. See, that's the advantage of PET. It will tell you small tumors, it will tell you lymph nodes, it will tell you nodes in the chest, it will tell you lung, it will tell you brain, it will tell you everything. This case warrants a PET. All cases don't warrant a PET. This case warrants a PET. Are you still going to resect? See, just because you are a surgeon and that this is a surgical meeting doesn't mean that every case that we present here has to be operated. That please keep that out of your mind. Remember, in a surgeon's career, there are 3 stages. In the first stage, he learns how to operate. In the second stage, he learns when to operate. And in the third stage, he learns when not to operate. Okay, so you have to reach each of these stages. And that you do by your experience, and you learn. As you learn, you will learn. So when you see multiple mets in the liver from a solitary papilloneoplasm, normally solitary papillomas are low-grade malignancies.
Yes.
So they don't spread. But once they spread, that means it's a high grade, because from the pleomorphic and other definitions on the FNSC, it looks like a high grade tumor. Okay. They didn't do a Ki-67 index, but if they had done that, we would have known what was the division rate and mortality rate. Okay. Because we have to ask other moderators to, other panelists who are sitting outside to speak also. Let us quickly finish. What will you do? One word now. Resection? No resection? If not resection, what? I will tell you my approach. I will call the medical oncologist and ask him to give upfront chemotherapy.
Yes.
I will ask him to do even aggressive chemotherapy. She's young, she's fit. So I'll ask him to give aggressive chemotherapy. And if this tumor shrinks and if the secondaries shrink, then I would plan for a single stage, probably require a pancreatic duodenectomy, looking at the size of the tumor and everything. And along with that, probably have to do a segment 7 and 6. Both has to be resected. So rather than doing a full right, I would do a 6 and 7 resection if possible. And I would get somebody with, I don't do too much of liver resection, so I'll get somebody with liver resection ready to do that along with it. Or do the Whipple, wait for 3 months, continue with the chemotherapy, and then go ahead and do another PET scan. And if it is not spread, go ahead and do the liver resection. Phani and Venkatrami for your final comments on the treatment line, and
Yes,
then
sir.
we'll open it to Shastri and Kapoor.
Yeah,
and all.
treatment, we agree with the same, sir. It requires actually systemic therapy and followed by that reassessment, and then decide whether it's regressing or not. And there is some role for radiotherapy also, but local radiotherapy may be given in certain cases. But otherwise, it's systemic chemotherapy systemic therapy that is the mainstay of treatment in this case.
Phani?
I mean, for the liver assessment, I would have liked if you said that, because there's some discrepancy between the PET and the CT findings, I'd get an MRI liver, which is the most sensitive investigation to.
Okay, we agree with that. Yeah.
Then I do agree. You have to go through an MDT. I mean, that's the most sensible answer. But SPEN is an area where there's not much role for chemotherapy. There's very little literature. So it's debatable. You would go for an upfront. In this, see, looking at the CT, head is free. You could probably do a distal pancreatectomy. You could, I mean, looking at
you could, or even just enucleation of the tumor if possible.
Yeah. So that,
but
and
pain
with
is
resection versus neoadjuvant chemo, it's a debatable thing.
Would you go for neoadjuvant chemo?
So in this case, there's no good evidence supporting neoadjuvant.
I mean, there's no evidence at all to suggest anything.
Even if carcinoma, I would have said neoadjuvant, though there's no literature. But
Yeah.
SPEN, I don't know if there's any chemotherapy at all for SPEN, actually, if you look at the literature. So
I don't know, we'll have to,
we are not the expert. We'll go through an
any-
MDT and then decide the.
Yeah, ask the medical oncologist. That's why I said I'll ask the medical oncologist whether he would like to give chemo. Suppose he refuses outright, then we have no other answers. We have to operate. But suppose he says, no, I will give some drugs and then see what happens. Then I would, I am not keen on operating on this patient straight away. I would like to have something to, reduce the thing and to know the biology of the tumor before I do.
And
So
the
I would
points
do a
I made, exactly, the
KI-67
KI-67 is a very useful thing. I think that gives us
very
the
useful.
idea.
I think we have to do a KI-67 to see the division, how much division there is. So I invite now open to the others, Shastri, Kapoor.
Ruchi,
Yes, sir. Yes, sir.
I think I know it's a difficult case, but the thing is, there are some basic things which you faltered.
Yes, sir.
Right, as Ramesh asked you, what are the signs of liver failure? These are the basic questions, actually. I think these should never miss. That gives a bad impression to the examiner that it's an undergraduate, it's taught at undergraduate. That is one. That you missed it. The second thing is such a large mass asking for a US is a blunder. I think you should have asked for a percutaneous biopsy in a palpable mass. And the first target is the liver mass, which you should target to look for a metastasis is what you should. And the third mistake I felt was that jumping to surgery without evaluating for metastatic disease. So you should have asked for a metastatic disease. You can't do upper surgery, particularly such a major surgery, without asking for
potentially a surgery that carries a potential mortality. Please remember, this operation could end up with a mortality because the splenic vein is involved. The arteries are all pushed. You might damage arteries, and then the patient may die. So you have to be very careful. Not to be attempted as the person who's doing his first or second Whipples or fifth Whipples. Somebody who's done 500, 600, yes, that's the person to have go in for this case, the most experienced surgeon in the team. So, and have other experienced members to assist him. Sometimes we forget that the assistants are very important, and we think first year MCHPG is good. No. I ask one of my senior consultants to wash with me, because we require decision making on the table, and we require 2 hands of equal skill. So we require 2 hands of equal skill for such cases. There's no harm in overdoing it a little bit rather than underdoing it. But I agree with comments of Rabella. Actually, I will tell you that if you had presented this long case in the examination, on this you would have failed. 100%. Because your approach was wrong. Your final approach was wrong, your investigating approach was wrong, and fundamental questions you failed to answer. So you would have failed. So you have to really pull your pants up. We are not harsh examiners. None of us are harsh examiners. But there are facts which we have to tell you, because at the end of it, you must know where you stood on this case.
Yes.
So in this case, probably you were not well prepared for some reason and you didn't have the ideas. But I think a little bit, and then, on the CT scan, the obvious findings you tell. He had to lead you to tell that there is calcifications. He had to sort of literally lead you by the hand. We are all showing you multiple calcifications. That's why I said we are asking for a plain CT. Why are we asking for the plain CT first? You should have known, no? See, these are all hints given by the examiners. We don't want to be harsh, so we give some hints. So when we say plain CT, not contrast, then you know what you're looking for. And you could see such gross calcification. So that is something that... would that calcification should have influenced you to think of SPEN more funny? I'm not sure about that. I don't know what is the finding of calcification.
All the cystic neoplasm will have
some calcification.
That's the problem.
Yeah.
But some of the serous ones have a stellate one in the middle.
Yes. No,
they don't have the peripheral.
More mucinous. Peripheral is in more
mucinous. Okay. Shastri is waiting for
regarding the treatment, I think we can excuse you because it's a rare tumor. But up to the general management, you should have followed the principles remain the same, right?
And the general management, see, even for the tumor, the management remains the same. Once you have metastatic disease and you plan to resect the metastatic disease, you must make sure there is no other metastatic disease, isn't it? That's the fundamental principles. Even if you're doing a colorectal secondaries in the liver, you would like to do a PET to see whether there is a lung met, brain mets, and then decide whether to resect. And invariably, nowadays, before resection, we always discuss with an oncologist whether he would like to give neoadjuvant, because they will tolerate it better upfront than later. Dr. Shastri?
Regarding the treatment, what we have done was that because there are only few we reviewed and only few case reports of SPEN metastasis was there, and there was a controversy also. So MDT was called for, and MDT, because the patient was a good risk patient, and we have initiated the platinum-based. I think platinum-based chemotherapy neoadjuvant was started for this patient, and then reassessed later at that point of time. There was the case.
They have thought exactly like your examiners have thought. See, among senior doctors, there is always usually a consensus. When there is a consensus and your opinion goes against the consensus, you are not, see, if all of us had different opinions, one person said resection, another person said radiation, another person said chemo, then we would have, your answers also would have been taken as a change of opinion. But here, everybody has, they have also gone the same as what we have all thought. So I think there are certain principles of malignancy which you should not avoid.
But Shastri.
Don't feel too bad about your performance, but just remember all the points made by Pradeep, which are very relevant in your examination anywhere. As far as I think the most important thing, your perception of a metastatic disease, that is crucial. A metastatic disease, still, it could be a curative. There is maybe a curative option. So unless you have a biopsy, you cannot proceed with anything. And as far as experience with SPEN and liver metastasis, yes, I have one case, SPEN with liver metastasis in a 25-year-old girl, which we thought was worth operating, but then at surgery, it turned out to be locally inoperable. The artery was thought of encased, and he thought it was not worthwhile. As far as chemotherapy is concerned, there are no reports at all of SPEN or a mucinous adenoma responding to chemotherapy. Well, in a desperate situation, we'll have to probably resort to unconventional treatments, and a multidisciplinary tumor board would be the answer for that. So these are a few comments I thought I should.
VK
Professor
Kapoor,
Kapoor, sir.
if you're there.
Morning, good morning, Pradeep.
Morning, sir.
After
Good
the
morning.
history, 27-year-old lady with kind of vague upper abdominal pain, you have to keep the possibility of peptic ulcer, chronic pancreatitis, cyst anywhere in the liver, in the pancreas, in the spleen, in the retroperitoneum, and obviously a splenomegaly. So you have to keep all these options and you have to consider them. Blood transfusion history, you could have answered that if I am thinking of a cystic lesion of the pancreas, whether there is a vascular complication which has led to bleeding, and that is why patient required blood transfusion. But then I don't remember whether history of hematemesis and melena was mentioned or not. And same
It was
could be
mentioned. There's no hematemesis melena.
Yeah. So then it is unlikely. And GIST, you should not make a clinical diagnosis of GIST unless there is history of GI bleed. Not that all GIST bleed, but clinical diagnosis of GIST should be made only if there is a GI bleed or there is a very large palpable lump which is after the examination. And again, at MCH level, you have to be able to mention, if not all, at least most of the signs of liver failure. On ultrasound, because we are seeing a mixed echogenic lesion in two organs, you have to keep the possibility of hydrated in mind. Plain CT calcification has already been emphasized. You can't ignore that. In fact, on plain CT itself, the mass also is seen. So that also you could have said that there is a mixed density mass with necrotic areas inside. You made a diagnosis of cyst adenoma, but cyst adenocarcinoma, but when you are making a diagnosis of a cyst adenocarcinoma in the pancreas, you have to first say which cyst. It could be serous cyst, it could be mucinous cyst. You have to first say what is the underlying disease. And then after seeing the CT, because most of the tumor is solid with necrotic areas, the first diagnosis probably should have been a solid pseudopapillary neoplasm rather than anything else. Although students need to remember that neuroendocrine tumors can have significant necrosis and they can appear as a cystic neoplasm, but then as you rightly said, they are brightly enhancing, and you have to use that adjective. They are brightly enhancing, not only enhancing, they are brightly enhancing. Whenever you have a primary and a metastasis, most of the times it is better to get the biopsy from or tissue from the metastasis, because that is what is going to decide your final management. You may not even need the tissue from the primary, and liver, it is much easier to get a tissue than any other organ. What approach to use for biopsy? I would slightly differ with Ramesh, because if possible, EUS is always better because it is a transvisceral rather than a transabdominal or a transparietal biopsy. And if the lesion can be accessed through the stomach, you can have an EUS guided true cut also. In the duodenum, it is not possible because it takes a curve. But if the scope is in the stomach and you can see the lesion, you can get a EUS guided true cut also. And these days, you have the facility of making a cell block, which the pathologist says as good as a true cut biopsy. Metastatic workup, again, it was an inexcusable mistake that you could not say, or you could not come up immediately with PET scan. You have to be able to say that. As far as management, and then CA. CA is important in fluid, not in the serum. When you have a cystic neoplasm, you get a fluid. Yes, CA is important. There, CA99 is not important, but in the serum, it is CA99. Treatment, neoadjuvant chemotherapy, there are two reasons. One, it can help to reduce the size of the primary tumor or the metastasis. But more important for me in a case like this, a young patient with malignancy, is to assess the biology of the disease. If after 1 or 2 cycles of chemotherapy, she throws another metastasis somewhere in the liver or somewhere else, I know that whatever I might do, this disease is not going to be cured. So most important use, in my opinion, of neoadjuvant chemotherapy in most of these malignancies is to assess the biology. I would not agree with Ramesh when he mentioned enucleation. A partial excision, whether if there is some amount of head of pancreas and some amount of body.
Yeah, that's what I meant. That's what I meant. Basically, that's what I meant.
Because enucleation is only for an
I didn't mean an enucleation. I meant a partial excision. I mean a partial excision.
2 or 3 general points. Many a time I noticed that you started answering a question, then you fumbled and then you stopped without completing. So if you don't know the answer, it is better to say in the beginning, I don't know, rather than make an incomplete statement. And second is that when a question is asked, answer that question. When you were asked, what is it? Then you said, it is not a pancreatic ductal adenocarcinoma. That is not the correct answer. First, you should say, what do you think it is? So don't give negative answers. Your answers should always be in positive. So students, please send me a mail, vkkapoor.india@gmail.com, write other pancreatic neoplasms. I'll send you a chapter on other pancreatic neoplasms from my book on pancreatic proteoctectomy. Thank you. Thank you, Pradeep.
Thank you, sir. Thank you, sir. Can you wind up, sir, Ramesh, sir?
Yes, I think we can wind up 9:30. Yes, I think we had a good discussion. A difficult case, but this is the type of case which you should now learn to handle, because you are going to be a consultant GI surgeon. So you'll be asked your opinion. So you need to know how to give an advice to not only to your patients, but maybe a GI surgeon may ask you. Another one may ask you, I have a case like that, what should I do? I do get phone calls from my students, from my people. So ask me and I tell them this is what I would do. Whether they follow it or not, I don't know. But I would tell them what I would do. But there are principles. So the guiding light for all students should be, have principles in your mind. Once you have principles, you follow that line. So for a malignancy with secondaries, the principles is, you know that this is an advanced disease. So therefore, you take every precaution to not do a major surgery till you know that the surgery will benefit the patient. So for that, you have to do a multidisciplinary meeting, you have to do a metastatic workup, including a PET scan today, and then go ahead and do the surgery if things are bad. So remember this, and all the best. Wish you. Thank you. Good night.
Thank you, Dr. Ramesh. Thank you, Venkatrami. Thank you, Phani. And thank you, Ruchi, and other faculty, Dr. Kapoor and Professor Shastri. Thank you.
Thank you, sir. Thank you.
Thank you.